Next, we come to Dr. Debabrata, our beloved Honorary General Secretary of CSI.
Thank you, sir, for your kind introduction, and a very good evening to Dr. Mohanan and all the dignitaries. So, I have been given the task of discussing on the antiplatelet management in ACS PCI. Now, the present day uh, paradigm is gradually shifting towards withdrawal of medicines that are found to be often unnecessary. And that is why will be looking towards aspirin-free strategy in ACS PCI. There is enough rationale behind this because aspirins are very gastrotoxic and they are known for producing bleeding. There are incidences of aspirin resistance, and if you use a higher dose, it will promote vasoconstriction. Of course, we now have more potent agents, the P2Y12 inhibitors. Now, it is pertinent to see whether such a strategy can reduce bleeding risk without compromising the ischemic risk. Why bleeding risk is important? Because both the ACUITY and the ADEPT test trials have shown that any major bleed within 30 days and even post-discharge can increase the risk of mortality significantly. Now, these are the latest trials starting from global leaders in 2018 to smart choice in 2020. Of these, the global leaders and the Twilight ACS sub-study are the largest one, and all of them has shown to reduce or the mortality or the adverse events or the major or the MACE without any significant difference in bleed or even as shown in Twilight ACS with a substantial risk of low bleeding. The special mention must be made about Twilight ACS because it is a very well-designed randomized controlled trial where ticagrelor with aspirin has been tried against ticagrelor alone for 12 months after a high-risk PCI, and they failed to show any major difference in death, MI, and stroke between the two groups with a substantial low risk of bleed. So if you divide the patients into two groups where the precise DAP score is less than 25, who are obviously the non-high bleeding risk, and those with a score of more than 25, who are the high bleeding risk group, and consider the patients who have undergone complex PCI or simple non-complex PCI. So what happens? So if you see the bleeding risk, obviously a short DAPT decreases bleed in both the groups and for both types of PCI. But if you consider ischemia and MACE, in the non-high bleeding risk group, the long DAPT performs better for complex PCI. And if you consider the high bleeding risk group, a short DAPT performs better both for complex and non-complex PCI as regards ischemia. But whenever it comes to MACE, short DAPT performs better than for non-complex PCI in the high bleeding risk group, but not for complex PCI. And that is why Dr. Deepak Bhatt once commented that if I undergo a complex PCI, probably, and I would like to have the DAPT continued even beyond 12 months, depending on the risk, of course. Now, as we see that in many cases, depending on the bleeding risk and depending on the ischemic risk, we can continue with a monotherapy agent. Now, which monotherapy agent we should choose? Obviously, ticagrelor and prasugrel is better than clopidogrel because they have more rapid, they have more greater and more consistent inhibition of platelet aggregation, which translates into more clinical benefit. And what is important, that there is no effect of CYP2C19 allele on ticagrelor and prasugrel. Because of this CYP2C19 function, if you have this CYP2C19 function loss allele, even if you increase the dose of clopidogrel to 600 milligram loading and 150 milligram maintenance, in the heterozygote allele, there will be only a 50% of efficacy of antiplatelet action, and in the homozygous allele, there will be even less. Now, whether we choose ticagrelor or prasugrel, as per the ESA REACT 5 trial, prasugrel has shown to be better than ticagrelor for reducing death, MI, stroke, or stent thrombosis with no difference in bleeding risk. However, this is debatable because in ESA REACT 5, those patients who have undergone angiogram are randomized to receive only a loading dose of prasugrel of 60 milligram and not ticagrelor. However, the ESC 2020 guideline has recommended prasugrelor as a loading dose before PCI as part of early invasive strategy. We have a newer entrant, the cantrelor, which is an IV agent and can be used for periprocedural use. It has proved to be better than clopidogrel and even crushed ticagrelor or prasugrel, and the effect is better with larger CK-MB elevation as shown in the Champion Phoenix trial. And what is important that there is no effect of co-administered opiates. The genetic or platelet reactivity testing has no proven efficacy, and it is shown that the newer generation stains with thinner strats and better biodegradable polymers, they gave better result with monotherapy. Now, this is the ESC, as per the ESC 2020 guideline on non-STEMI, which is published recently in 2021. It is the bleeding risk which predominantly determines the strategy to be followed. If you have a very high bleeding risk, it is always prudent to go for a 1 month therapy with aspirin and clopidogrel, followed by clopidogrel monotherapy. The same is true for a high bleeding risk patient. However, the DAPT can be continued for 3 months. If you have a low bleeding risk, depending on the ischemic risk, you can continue DAPT for 12 months or beyond. And if you consider monotherapy, you can continue DAPT for 3 months as per the twilight regimen, and then continue the ticagrelor monotherapy as per the bleeding risk. Thank you. Thank you for your patience here.
Thank you, Dr. Debabrata Rai, for a very to the point, giving some very valuable insights into the problem of deciding as to which and how long antiplatelets to be used in the case of ACS with PCI.
With prasugrel, I have used prasugrel in more than 1,000 patients in patients whose ischemic burden is very high. But recently, I had a patient who is 36-year-old, and he has got familial hypercholesterolemia. His cholesterol is 370 milligrams per deciliter, and I had a very difficult stenting on this patient because the surgeon refused the patient's prop I and enzymes were high. Actually, it was a case of NSTEMI, and so they refused to do. And naturally, we had to take the patient. We normally don't give also, but anyhow, I had a consultation and I had a heart team approach. And we did it, but you know, even for 5 seconds, we were inflating the balloon, and it's the stent, and you know, we had a V-stenting, ideal set for V-stenting, and the results were fascinating, very good. But the patient, after 6 months of prasugrel plus aspirin 75, his weight is also near 90 kg. He had a subdural hemorrhage. So we had to stop, send for evacuation surgery.
Okay, that's
so what is pertinent for Germans, I think, because this patient has got, you know, high ischemic risk, and it was ideally given, you know. So prasugrel, after 1,000 patients, one patient, I got a subdural hemorrhage.
Okay, I would refer you to 2 important trials which has been presented this year, 2021. One is a Talos AMI trial, Korean trial, where the short duration of DAPT with clopidogrel only as against clopidogrel aspirin had a better outcome both in terms of hemorrhage as well as ischemic events. The same type of post-exam trial is another trial where they used clopidogrel instead of aspirin after 6 to 18 months of STEMI, and they found the bleeding is less and the outcome is better. Now, if you look at the top DAP trial, the Japanese trial, or Smart Choice trial is a Korean trial, there also they found that short duration of DAPT involving only clopidogrel occasionally, no aspirin, showing better outcome in terms of ischemic and bleeding event as well. So that brings us to a very important issue, whether the Asians are more bleeder, they tolerate clopidogrel better than the other P2Y12 inhibitors or not. That is a very important issue that should be kept in mind. And the second is a very recent meta-analysis of de-escalation. De-escalation could be either by changing the P2Y inhibitor from Tika, Presu to clopidogrel, or it could be from changing from DAP to SAP, dual antiplatelet to single antiplatelet. By and large, it has been shown that if the bleeding risk is the thrombotic risk is not very high, then 1 month DAPT, because this 1 month is very important from ischemic point of view, whereas bleeding is important from the rest of the 1 year. But from ischemic point of view, from stent thrombosis point of view, first 1 month is very important. So all the patients should receive DAPT first month if there is no high bleeding risk, preferably up to 6 months with newer stents. And thereafter, the choice is between ischemia and thrombosis, and individualize the choice. My personal opinion is that long run or long DAPT probably is better with clopidogrel aspirin or only clopidogrel, but I don't know as yet, because still the textbooks say that for secondary prevention, indefinite period of aspirin is recommended. You have not changed it. If it is a question of years, 3 years, 4 years, probably aspirin to be continued. But changes are in view in the horizon in terms of shifting from aspirin to clopidogrel.
Sir, can I come in for 30 seconds? Just 30.
Sorry?
Yeah, Dr. Dutta, just one more point I want to say is a Pegasus trial, in which ticagrelor has been given at both 90 and 60 milligram BD doses. So that's one evidence of using.
That's why I said the de-escalation in terms of changing the white dose as well as in terms of changing the P2Y inhibitor.
1 year, yeah.
The other point which I just want to bring in, is what is the opinion of the House on the role of, so since I was dealing with non-PCI cases, non-stent cases, of the use of adding rivaroxaban to a dual antiplatelet or a single antiplatelet in the first year of therapy. Now, this is the evidence from the Atlas to ACS TME50.
That was Atlas ACS trial was long time back, so to say, and it was not all the patients did not receive the PCI, and we now probably not in a position to consider NOACs unless the patient is in atrial fibrillation. The guidelines recommendation does not recommend.
Imran, may I have a quick comment?
Yes,
when Atlas was given, nobody was on ticagrelor. So
Yes,
nowadays, everybody in ACS is on ticagrelor. So that's why rivaroxaban never was popular in the ACS patient on top of antiplatelet. But if you see the compass, it is after 1 year of successful uneventful dual antiplatelet. Only after that you are replacing the other antiplatelet. So I think that Dr. Dutta has given the sum up in one, maybe unknowingly also, that in the first month is the ischemia prevails. And then the ischemia flattens out throughout the rest of the life of the patient. But bleeding remains high throughout the rest of the life.
Exactly.
So that is why it is counterintuitive that you are giving 2 antiplatelet versus 1 antiplatelet and your event rate is not changing. How come? How come the ischemia is not less? So are these dummy tablets? No, the thing is that the event is so less after first 1 month that is very difficult to get a statistically significant difference in the ischemic event.
And newer
event is statistically significant, we could improve that. I think
the importance of the newer generation stent.
And newer generation stents.
Exactly. That is why I was just mentioned. That is important.
Sir,
I think time is up. Debdatta, make a final comment and we'll
Sir, just a question to my esteemed teachers that are you really comfortable of completely removing antiplatelets altogether in a background of oral anticoagulant therapy? That is my question.
As a
Yeah,
chairperson, I would say no.
Platelets.
I see it's a FIR trial. I think the FIR trial has shown that single NOAC after 1 year
No, that
is enough.
again class 1. FIR is not a trial with ACS. It was a chronic stable angina.
So, no, so even after ACS, after 1 year, it becomes a chronic stable kind of thing. You know, if you don't have an episode of ACS in between.
I think we need more trials to be confident enough to withdraw the antiplatelets altogether and keep the patients on oral anticoagulants, as the doctor has suggested.
No,
So we
Debdatta,
cannot still be confident about it.
very quickly, Debdatta, when you are talking about a patient after 1 year, only NOAC because you are giving the NOAC in full. But in Compass trial, when you are giving
So
the
if you kindly wrap up the session and let us go because I have a lecture in Bihar CSI. Otherwise, I'll have to go over there.
thanks to all the previous faculty.